The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. We're coming to you live from EMS World Expo. Got my good buddy Tyler Christofoli from the Lifestar Podcast, and obviously you guys know him. He's done a lot of amazing blog writings. Love reading his stuff for us, and we've actually been talking. He's going to start coming on board and teaching some of our review classes. So very, very excited to have him as part of our team, and I think everybody's going to be blown away by his abilities, and I know he's probably wanting to punch me right now, but he really is talented, and so excited to have him as part of the team, and so we're going to do a podcast, and wanted to introduce him. He's been on the podcast before, so how you doing, dude?
Doing great, man. Doing awesome. Yeah, I was talking to Eric yesterday, and he's like, hey, you want to help me out with some review courses? And that's crazy, because I learned all my stuff to take the FPC through FlightBridgeED, so I thought it was phenomenal when you asked me that. I'm honored, man. This is great. I'm looking forward to this.
Well, I think it's truly a blessing and very humbling, the road that we've taken as far as FlightBridgeED and the growth, and we're to the point where I am absolutely maxed out, and I think it's important to keep that life balance, with my family, and I just and let's be honest, I'm not getting any younger. I want to just be able to have also a backup to where I have somebody else that can step into my lectures, and that's where I've really been careful to select that person, and I want that person to be you, to where if I'm not at a course, I'm unavailable, or if we have duplicate courses going on at the same time, that you can step in that role and take the lectures that I teach, and so it would be you or Mike. It could be you and Bruce Hoffman, taking the reins, and so I'm excited about that.
Yeah, man, I'm looking forward to joining the team. This is going to be awesome. It'll be fun.
Yeah, awesome. So today's podcast, it's kind of funny. Tyler asked me, hey, can you send me a script? And I texted him back, and I said negative.
I just wanted an outline, man. Yeah. I've had 4 cups of coffee. I'm feeling jazzed right now, so I can't promise that Evan's not going to have to do a whole lot of editing on this one.
No, it's all good. So we are going to do a podcast. This is something that actually came from your podcast on, do you stay and play, or do you get off the scene and haul ass? Do you want to kind of talk about the theory of that podcast if you haven't heard of it?
Absolutely. Yeah, so if you think about the paradigm of ROSC, usually what it's been is that we get a pulse back, and if we get the patient to the hospital with a pulse, then we was a save, right? And so we miss stuff. We miss huge things sometimes. We're not taking blood sugars. We're not doing 12-lead EKGs because we're scooping and we're running to the hospital as fast as we can. And so in that podcast, I just encourage the providers to take a few minutes, step away from it, look at what's going on, and almost look at it like it's a brand new patient. This is the first time I'm seeing this patient. I'm going to reevaluate my vital signs. Things that really sound simple, but when you think about it, we miss it, because what do? We strap them to a longboard, we take them down to the ambulance, we go emergent to the hospital, and we deliver them with a map in the 40s, and their kidneys are shot, they got no brain perfusion, and we didn't really think about all that because we were just so focused on just getting them to that hospital. And so we just wanted to look, it is important. I mean, there are patients that absolutely need to get to a cath lab. They need thrombolytics. They need something that we cannot provide. But none of that's going to mean anything if you're getting them there in an unstable condition. And so that's really the message I was trying to send across. I had excellent feedback, and I feel like a lot of us are on the same page with that.
Yeah, and I think I think it resonated with me immediately, because this is the same concept that Dr. Antevi has taken, and his kind of vision for his pediatric system is, instead of grabbing the baby and rushing out to your ambulance and getting going, he really teaches to stop, resuscitate on scene. Even if you're on scene for 15 minutes, that delay in compressions, that delay in care is so pivotal to not have, I should say. It's pivotal to start that. And it's the same concept.
Oh, absolutely.
Slow down.
And if you look at the heart rate zones, you'll see like 100 to 115, you start getting into that alert phase, right? Your sympathetic drive's kicking in a little bit, you're feeling good. You get above 115, you start losing those fine motor skills. So I want you to imagine a patient that you just resuscitated, your heart rate's already up, you strap them to a board, you're walking out to the ambulance, trying to get them down a flight of steps. You finally get out to the truck, your fine motor skills, your thoughts start to deteriorate a little bit. All that plays into it, and that's stuff we have to consider. And I think that if we're just grabbing the patients and running out, like Dr. Antevi brought up yesterday, you're doing a serious disservice to the patient.
Yeah.
Take those few minutes. I'm not talking taking 20 minutes, but I'm saying take 5-10 minutes and stabilize them. Start your pressors right there. Think about long-term sedation if you already have the patient intubated. They're going to feel that. Think about all of those things and don't just say, all right, I got a pulse back, I got to run.
Right. Well, I think those are great points. So this podcast, guys, is going to be kind of based on that. I think, you never know where my mind's going to go. And I'm a little worried.
These are the best ones.
Yeah, I was sitting there dreaming about Tyler, and his hair. And
he's got some good hair.
If you look
really
at the table right now, they're both on one side, and I'm on the other side like I'm being interviewed for a job. So
yeah,
maybe, I don't know. Something like that.
Yeah.
But follicles of steel. If you saw my tweet,
I think the picture for this podcast should be the one that all of us with my hair.
Yeah, somebody was it Sam that did that?
Yeah.
Put his hair on Eric and I. It was pretty good.
Paybacks for can't say it on this podcast. We could say it on second shift, but so this podcast is going to be named Fallacy or Fact: Misguided Medicine in a Pre-Hospital Critical Care Environment.
Ooh, I love it, man.
Are you ready?
I'm ready.
I think it's you see a lot right now in on MSN or these fake ads, the fake news.
Fake news.
Well, we have the fake news of EMS, right? Where somebody may hear a explanation of research, and they take a quarter of that and they run with it.
Or my favorite part is where they look at the title, they go to the conclusion and go, "Oh my God, ketamine must kill people when it's used with people with a shock state, right? Oh my gosh, shock score greater than 0.09. It's bad. It kills them." Well,
so that's just he was done on 4 mice in a bathtub.
Well, exactly. And the mice woke up and their liver was gone, but their kidney was gone. Right.
So one of the definitions that I looked up is what does fallacy really mean? And fallacy is a bad argument that tends to persuade us even though it's faulty.
Yeah.
Or an argument that contains a mistake in reasoning.
And we're surrounded by them.
Absolutely.
We are. I'll tell you, and I don't want to jump right in, but I got one right off the bat for you. A few months ago, there was just a tragic story of a 4 or 5-year-old kid that drowned in Texas. I don't know if you guys remember that. And there was all kinds of news reported on all the major outlets that it was the secondary drowning syndrome and the dry drowning and all these like magical terms surrounding the physiology of what happens when somebody drowns and why this kid died later on. And it actually created quite a ruckus, right? And according to all the principles that deal with drowning and the process of drowning and the research involved in it, there's only 2 outcomes to a drowning. It's fatal or it's non-fatal, with an injury or without an injury. That's the only way drownings are classified. But what happens is you get some maybe not necessarily fake news, but it's sort of they hear this thing called a dry drowning and they think, oh, that's a huge headline, let's go with that. So that's just one example of the stuff that we're talking about.
Yeah. No, and I think that's great. That's a great example. So then I looked up, I'm like, okay, well, what is a logical fallacy? A logical fallacy is an incorrect or intentionally misleading application of information. And I wouldn't say that we intentionally mislead people, but I don't think we actively listen. And I think if I reflect back on myself, you're so ready to speak. You're listening to somebody, you're so ready for a response, And do you hear everything that they just said, right? And that's kind of goes back to, be slow to speak and quick to listen, right? So here's the first one, and we're going to ask Tyler, and then we can all talk about it.
So this is fact or fallacy?
Fallacy or fact?
Oh, I said it wrong.
Ketamine causes arrest in hemodynamically unstable patients.
All right, so my opinion on this is if your patient, and this is funny because we just had this situation occur the other day, if your patient is in a shock state, and they're right on the edge, you are going to get a catecholamine release with giving ketamine. And so you have to kind of think about, am I going to push that patient over the edge if I give somebody who is in a cardiogenic shock the normal dose of epi? Or the normal dose of ketamine.
Right.
I say epi because you're going to get a catecholamine release from it. And so what we'll do is we'll look at reducing the dose on that. And so I have to say that is fact. I think if you are giving a patient the full dose of ketamine, there is a chance you could actually go the opposite direction, because we're going to be waiting for an increase in blood pressure like we would typically see with ketamine. But if you're doing it in the hemodynamically unstable patient, Scott Weingart has a really cool little infographic on it. It talks about reducing your dose actually significantly for those types of patients.
So let me add something to that caveat. Let me say this. Fallacy or fact, etomidate causes arrest in hemodynamically unstable patients. Versed causes arrest in hemodynamically unstable patients.
I think that to just say a drug causes arrest is really setting yourself up for failure.
Okay.
Because people could say propofol causes hypotension.
Okay.
It always causes hypotension. But if you look at dosing it properly, it shouldn't cause hypotension. Okay. It should be shock trauma. I remember Weingart talking about using propofol and reducing the dose by a significant amount, but that taught them to understand how protein binding works in plasma. Understanding that when you give a medication, a lot of that medication might actually be bound to those plasma proteins, and you might only have a little bit release or a little bit left for bioavailability. So if you're giving a patient a drug and they have a low blood pressure or they're exsanguinating, then you don't have to give as much because you're not going to have that protein binding. So I think you're going to have to look at doses, and I don't think you can just say blanket statements like that.
So if I go back and I ask you the question again, fallacy or fact, ketamine causes arrest in hemodynamically unstable patients, could you legitimately say that's a fallacy? Or could you almost say that really in any low perfusion state, regardless of the medication for induction, if we don't resuscitate that patient first, that really any medication you give could cause arrest in that setting?
Absolutely.
I think
you have to really think about the patient, resuscitation, protein binding, understand how that works. Does the drug even matter for protein binding? And then you have to look at the dosing of it.
Okay, awesome. So I bring that up because I have to say that I've heard a lot recently, specifically in my area, the rumor mill about, hey, ketamine is causing cardiac arrest in RSI patients, post-arrest, after RSI.
I hear the same thing.
Yeah, and obviously we saw a study come out last year on the whole low perfusion state. I did that podcast on that, and they looked at a total of 125 patients. Only 8 of those patients had hypotension, but all those patients were actually dosed prior to ketamine with either Versed or morphine, right? And so I think, like Mike just said, if you read the title and then you read the conclusion and you don't read the body of work, you can easily grasp onto that title and it kind of rock your boat. So I did a podcast with Dr. Dan Davis. Dr. Dan Davis is not only now our new chief medical director, which is absolutely an amazing thing. We're very like-minded in our thought processes, but he's also the scientific advisor and medical director for Air Methods Corporation for California, and their scientific advisor. And so, I did a podcast and we talked about a lot of this stuff, and unfortunately the podcast kind of got ruined, and so we're going to have to record that. But one of the things I asked him was based on that rumor. And I just want to put it out now. I can't wait to record another one with him, but I got to put this out now. And so I asked him, I said, what is the data showing? Because Dan Davis and Dave Olvera have collected over 6,000 intubations more than anybody in the world. And they're able to extrapolate over 200 data points. And one of the things they looked at is hey, do we have cardiac arrest? And so they looked at pre-2013. And they identified, how many patients do we have that arrest? And during that time, we used etomidate as our primary induction agent. We actually used fentanyl as our kind of pain dose, right, which has now been since removed. And they looked at those numbers. You move past 2013 until now, we moved to ketamine as our primary induction agent, and primarily for those low perfusion states. We really pushed as an education staff to use ketamine based on its hemodynamic properties of blocking those muscarinic receptors, right, which are parasympathetic receptors, and getting that kind of little bump in blood pressure, heart rate. And so in those low perfusion states, the ketamine was the primary medication. So they looked at those years, and they extrapolated the data, and there were patients that arrested after ketamine use in those low perfusion states. And so I said, okay, so is ketamine causing cardiac arrest? Is it the cause? And he says, well, my initial assumption, based on just the surface of looking at the data, I said, yeah. But then what they did is they compared the 2 years, or the two segments. They looked at patients previous, and they looked at patients in ketamine. So etomidate versus ketamine. And his exact words were, there was no difference in the amount of patients that arrested. And it really encompasses 1%. So pre and post, 1% of all the RSI patients had an arrest situation. Post RSI. So it didn't matter the medication. That's the fallacy or fact here, is that people are hearing a portion of that research. They forget the latter part of what I just talked about, that there was no difference in the numbers, whether they were given etomidate or they were giving ketamine. And the same amount of patients arrested.
And to take somebody in a low perfusion state and say, oh, this is the reason why they arrested. I mean, if they're in a low perfusion state, they're in shock. They could have arrested for a number of reasons.
Yeah.
I don't know if you can correlate that to an actual medication. Now you could say, well, I just gave this medication in then 5 minutes, and you're looking at, a causation and effect, and you're trying to figure out, did I cause that or not? I think we all know that, you can cause hypotension if you slam ketamine in somebody and you slam 2 milligrams per kilogram in a hemodynamically unstable patient.
Yeah.
I don't think you really need a study to know that. We all know that. But to just say, well, ketamine causes arrest, I don't think you'll ever hear a clinician that really is in the know just say a blanket statement like that.
Yeah, so we have to be really, really careful not to grab onto misleading statements like that. And I have no problem saying that. And the data shows that. It's not ketamine's fault. It doesn't mean we stop giving ketamine in low perfusion states. If you think about it, we're giving ketamine to the sickest of the sick patients in low perfusion states. Some of those patients are going to arrest. Had nothing to do with the medication. It could be their injuries, their hemorrhagic shock. It could be a lot of different aspects of their disease process. But what that leads me to believe is that as a industry, and I'll say industry, we're very poor, and this goes back to why I came up with this title based on your podcast, is we rush in. And if you guys go back to my podcast on damage control RSI, that podcast was specifically based on that mindset of slow the frick down, slow down. Don't rush in and get tunnel vision on, oh my gosh, we have to get this advanced airway, we got to intubate this patient. You have BLS procedures, and I always say we're ALS providers, but we're only as good as our BLS abilities, right? Mm-hmm. We got to go back to our BLS foundational procedures.
And we're in a world right now of evidence-based medicine, and we're really trying to, and that's awesome. I mean, that's great that we're doing that, but we got to make sure we know how to interpret evidence-based medicine. Because, I mean, you can do a study showing one thing that somebody else does a study and shows the complete opposite of it. And it was funny, yesterday, I was running the salad booth over there with the Ducanto catheter at the SCORE booth, and I was showing them how you can put the Ducanto catheter in the esophagus, and one of the girls said, well, do you have a study showing that doesn't affect oxygenation? And I was like, well, I'm putting it in the stomach, right? So there's no oxygen in the stomach. Well, I need evidence to see that actually, and I'm like, that's good that she's demanding evidence, but maybe not everything needs a study, right? We don't need a study showing what happens if one person does CPR and the other person doesn't do CPR.
Yeah.
Some of it you can kind of just interpret.
Right.
Or we don't want to read the whole thing, so we just read the conclusion at the end. I'm reading the NAP4 trials right now, and it says right in the front that it's level 5 evidence, which is expert opinion, which is the lowest level of evidence-based medicine that you can get.
Yeah.
But there is still some merit to it. MCRIT just put out a podcast. Paul Merrick said that, his whole fluid thing he's doing right now and how fluids are horrible, and he based it off of the FEAST trial, which was a single study. And I agree. I was talking to one of the providers here. He said, what do you think about the whole fluid thing going on with sepsis? And I said, here's the 2 things I think. I think we give way too much fluid in the field, and I think, 2, we don't start pressors early enough.
Yeah.
If you look at the Frank Starling curve, you're going to see you reach a point of diminishing returns. Once, if the patient's going to be fluid responsive, you're going to see it pretty soon. And then if you keep giving them fluid, it's not going to improve cardiac output. And so to have a patient with a MAP of 40 and to sit there and go, well, let's try giving another liter. Let's try doing another liter. That's time that the kidneys are not being perfused appropriately. And I think you can switch to pressors. And I know I'm getting off on another topic, but it kind of falls under the same line of we read one thing, and that's where me and you got to be careful with what we say, because if we say something, there's a lot of people that take it for gold. Oh yeah, that's what Eric Bauer said from FlightBridge.
Yeah.
It's got to be true.
Yeah.
And that doesn't hold so much when you're in the emergency room trying to explain it to the physician. I heard it on a FlightBridgeED podcast or the LifeStar podcast. And it's a little bit heavy. I just did that blog about the art of being wrong.
It's really heavy.
Yeah, and you can worry so much. I do. I worry so much that I'm going to say the wrong thing or I'm going to be misinformed on a certain topic that I spend so much time just reading and reading and reading, and I still feel like the more I read, the more I forget, and I got to catch up on it. But you have providers that come up to you and they look at you as leaders in the industry, and they look at you as an expert on that topic, and they say, Mike, what do you think about this?
Oh,
and then
I know.
you give them that answer.
Mm-hmm. And that's gospel. They're going to go tell 100 people.
And they take it for, and I really think that, you can get inspired by people in phom ed, but if you're going to change your clinical practice, it really, really needs to come from your full understanding and thorough knowledge on that topic, not just because you heard it on a podcast.
Yeah, and that's interesting that you bring that up. I mean, I think, I agree with you on the fluid thing. I think Paul Merrick is a brilliant guy, brilliant doctor, and I think a lot of the stuff he does is spot on, to be honest with you. I mean, I think a lot of the things, what happens when you give volume, right? Your SVR, slowly we're going to dilate out, which, if you're in that inflammatory response already, that's going to, with additional nitric oxide and all those things. We know kind of the cascade of events. And so I think a lot of his theories are spot on. Passive leg raising, being definitive in why you're giving fluid, I love it. And I've incorporated that in the review class. That's in my talk on Friday, is some of those concepts, because I think there's some brilliance to them. And I think the more and more I read, the more and more I research, it comes back to, seems like we're doing more and more stuff at the basic level. You go back 20 years, passive leg raising, that's first aid. Think about the volume, the stored volume that we have in our legs. 15 to 20% is stored in our legs. So, and as far as the expert aspect, I think the thing that you said that resonated with me is Alan Wolf. I talk about Alan Wolf all the time, right? One of my great friends and one of the true mentors I've had in the last 5 years. Love him to death. Have taught with him now for 5 years, and it's funny, when I went to the corporate side and was the clinical education manager at the corporate level, and we teach new hire, he always started off and he said, he would talk about me. I think sometimes just to razz me, but he would talk about Eric Bauer and FlightBridgeED Podcast, but he would explain that is level 5. That is expert opinion only. Just because, again, and I have no problems with that, because people come in, they've listened to the podcast for years, and they take what I say as gospel. And that's why there's a disclaimer in the beginning of the podcast. It's because medicine is so broad. There's so many pathways you can go down that may not relate to your system or the area you work or, what you're doing protocol-wise. And so, I never had any problem with him saying that. And I think what you just said is spot on.
And it's okay to say, you know what, man?
It is.
I don't know.
Yeah.
If somebody comes to you and asks you something that you got no clue, then I just be right up front with them. I tell them I have no idea, but I know a bunch of spots that I could probably find out.
Yeah.
And I get back to them. It's hard to say it. I hate saying I don't know. I hate it so much. But I do find holes in my knowledge then, and it makes it easier for me to fill those up. And that's why I like talking to people like you and like my friend Sam Ireland and people who constantly challenge you. Because if you always feel like you're the smartest guy in the room and that you got to like kind of bring stuff down and not talk so high over people's levels and stuff, then you're not going to improve yourself.
Right.
You're going to improve people around you, but you do have to improve yourself as well.
Yeah, I think that's true. You got to stay humble, and there's still questions I get all the time that I don't know, but it has a fire burning in me, just like you. It angers me inside that I don't know, but I go and seek out that information, and I think that's healthy. We should be that way, and I think people can see through that. If you try to,
they know when you're making up
somebody,
something on the spot.
Oh yeah, and so I've learned just be humble and own up to it, and then seek it out. All right, here's the next one. This is one of your passions, dude.
I can read his phone from where I'm sitting, and I know where this is going.
Don't do it. I got my font at like 80 font because I'm going blind.
I know, I see that.
I'm actually getting what's called refractive lens replacement.
Oh, really?
In December and January, where I'll never have vision problems again.
No, that'll be nice.
Oh, man. Talk about feeling old as these. Sorry, fallacy or fact? You shouldn't give PEEP in obstructive lung patients that are in failure, right? With all this auto PEEP, no PEEP, no PEEP. So Tyler, for all the listeners out there, this is one of the most controversial topics. He's stretching right now. He's like, oh man, what's your thought on this?
So me and Eric went through this, and we went back and forth with a chain of emails, and look at this, look at that. He sent me some really cool stuff on like the waterfall effect of PEEP. And we look at patients with obstruction and we really say that they're one patient, but they're really not. So you have asthmatics, which is an actual airway caliber reduction, and then you have patients with COPD, where it's more of a parenchymal elasticity issue. And so when you're thinking about adding PEEP to an obstructive patient, you got to classify, is this a reduced in airway caliber, or is this your emphysema type patient? And it doesn't make sense to me to apply PEEP if it's a airway caliber reduction, because you're not going to stent open the bronchioles with air. That doesn't really make sense. You really need pharmaceutical intervention. You got to treat that. But if it's a patient that has emphysema, what do they do when we find them? They self-PEEP. They're tripoding. Right. They're pursed-lip breathing. They're trying to create PEEP. So I do feel like those patients need PEEP. And in my anecdotal clinical experience, I have seen them respond very well to PEEP. But you have to be extremely careful, because you are going to meet an area where you're going to have diminishing returns, where you're not holding that elasticity open. You're not holding those open anymore, and you're actually aiding, or I should say disabling, their ability to fully exhale. So you really have to separate those into two different types of patients. So fact or fallacy, obstructive patients can't receive PEEP. That's too broad of a statement. You have to break it down. You have to extrapolate each form of obstruction and then see if it makes sense to that patient.
Okay, so correct me if I'm wrong. So you believe that COPD patients, so those chronic kind of disease processes, versus maybe an asthma patient.
So like emphysema, bronchitis,
Yep. That utilizing that waterfall effect, which for those of you, it's in the ventilator book. It's a study done by Cleveland Clinic, which is, obviously one of the top heart hospitals in the world. So it's not a fly-by-night place. I mean, this is a, legitimate research article, and they and I've ran this concept by RTs, and I haven't found, I've found a few that don't really subscribe to it, but I've found the majority that agree 100% that essentially what you were saying is you don't want to hit that critical airway closure. So can you explain kind of how you would approach that?
Yeah, so I don't, they say 75%.
Yep.
I don't know if I would say, all of them just need 75%. So I'm really going to watch my VTE, and I'm going to watch that tidal volume coming back, and I'm going to see if it starts improving if I add small increments of PEEP. I'm not going all the ways up, but I'm going to add it. And if I start adding PEEP and I'm seeing that it's affecting their ability to exhale, and I'm starting to see like a rise in end tidal or something like that, then I'll know, all right, I need to dial it back down a little bit. And you don't want to bring your PEEP up too much, because then you start worrying about hemodynamic compromise and all that stuff as well. But I do feel like adding, put 5 of PEEP on, turn it up a little bit more. Watch, see, do they look like they're improving? Are you able to stent open that parenchymal elastin, and are you able to aid in that oxygenation? And if you are, I feel like it's going to be somewhat subjective, because you're going to have to use markers. And I know, like we had talked about, should you use VTE? Should you use peak pressures? Which one of these should you actually be looking at as a reliable source? And I think it's going to be a collaboration of like all of them. I think you're really going to need to look at all of these, and we were looking at, can you look at plateau pressures? What marker can you use to say, hey, this is actually working? I think you got to look at overall appearance of the patient. I think you got to look at their work of breathing.
Right.
I do feel, and I know you probably disagree, but like VTE is important for me to look at. And
I agree.
That can be somewhat skewed by other things. Obviously, if you have a leak in your circuit or something, but if your equipment's all pretty good, I feel like you can look at VTE. That's a pretty important number for me to look at. And then I'll start titrating that up. So is it 75%? I'm not going off of that. I'm not just empirically setting there to 75% of whatever their intrinsic PEEP is. For one, because I might have a cult PEEP that I'm not even seeing, right? I'm only going to get PEEP of the nearest closure of the airway. So if they are completely closed down, they could have PEEP on the other side of that obstruction that I'm not even seeing. And so it's really hard to measure auto PEEP in a patient that isn't paralyzed. And I think we know that. I mean, that's very commonly expressed, that it's difficult to do that, but we do it all the time. And we try to get a static PEEP on them. And I did an experiment, and I was looking at static versus dynamic PEEP. And your dynamic PEEP is very unreliable, and it can change a lot. And I actually obstructed like an ET tube, and I put this up on the Foam Frat blog if you check it out. But I looked to see what the auto PEEP is, and I reduced that caliber significantly. I used like a pen, and I took the inside of a pen out, put that in an ET tube, and I put like a coffee straw in there, and then in the auto PEEP in it was like nothing. And I'm like, that's crazy. How am I not getting auto PEEP? Like, I can actually see the test lungs staying fully inflated, but my PEEPs were like nothing. They were right as what I had set the ventilator to. And then I did a E-hold, and then they were off the records. Like, they were huge. And I thought, this is really interesting to me, because how many times do we just look at our waveform and say, oh, that must be what my auto PEEP is? But when I actually did a static E-hold, then I was able to see the actual auto PEEP. And so I thought, this is cool. This is, and how much this relates to clinical practice rather than a bunch of pens stacked in an ET tube, who knows? But I did read several articles stating that static PEEP is better than dynamic PEEP. You're going to get a more accurate look at that. And now that's what I do. And I don't paralyze all my intubated patients.
No.
I kind of like to just keep them comfortable. Yeah. And I remember one of my firefighting instructors, and I just owned up to being a firefighter, but one of my firefighting instructors said, when you walk into a room and you see the room on fire, don't hit it right away with water, because that's going to be the best view you have until you hit it with water. Then it's going to go black. And how I extrapolate that to clinical medicine is, when I look at my patient before they're paralyzed, that's going to let me know how comfortable they are. Right. That's going to give me all those factors. And then if I just paralyze them, I just hit that fire with water, I blacked out the room, and now I'm playing the role of their brain. And I'm controlling their respiratory rate, I'm controlling their comfort, and I'm looking at heart rate and end tidal, but you really got to get a good picture. So I don't paralyze all my patients. I try to stay away from it if I can. And with that being said, then you can have the patient cough and have a wrong, E-hold when you do it, or you can have different things that can obscure that. So go back to what you said. I think that I'm not sticking to just 75%. I'm titrating that to my VTE, and we did I did a podcast on this. We talked about this a lot.
Yeah.
But to say that you can't give PEEP to obstructive patients, I just don't think that makes sense.
Yeah, so we went back and forth. I mean, I think primarily what you're going to see if your auto PEEP continues to increase is, and we talked about, does your VTE increase, does it decrease? I think 99% of the time you're going to have a decrease in VTE. It's going to continue to drop.
And if you have a nebulizer on and you're running it off the wall, then your VTE is going to change a little bit more. And so that was something Sam and I were talking about, because we're like, all right, so in obstructive patients, if it's an asthmatic, very commonly they are going to have a nebulizer running. They could. And so your VTEs could change a little bit. So you kind of got to know where you were before you added it and then titrate the lead. It can get very confusing, and you really got to know what you're doing if you're going to make that happen.
I wonder if you could actually apply the concepts of a recruitment maneuver and look at specifically, and I did a podcast on this, in an oxygenation patient, obviously we would do this, and it's to utilize the maximal amount of PEEP to where your static compliance doesn't start going the opposite direction. So essentially you're starting at 5 a PEEP, right? You're going to check a plateau pressure, evaluate what your static compliance is, what your plateau pressure is, then increase your PEEP, let's say to 8, do again, another plateau, static compliance. And as long as your static compliance is improving, right? So you keep increasing your PEEP until your static compliance goes the opposite direction.
Mm-hmm.
And then that's the maximum PEEP you would use on that patient. So I wonder if you could apply that same concept, because ultimately what we're saying when you're using the waterfall effect is what you're doing is you're bringing your driving pressure lower. Your opening pressure gets dropped down, right? Until, as Tyler said, you get to that point where if you exceed that 75%, or if the pool, and it's kind of hard to illustrate this, but imagine a river, and then that river flows off a waterfall, and then you have a pool, a big pool at the bottom. If that pool keeps coming up and coming up over the top of the waterfall, at that point, that's that critical airway closure. And Tyler's got this on his blog. I did a podcast specifically on this topic, and I've got that article on the podcast in the show notes, so you can check that out, or it's in the ventilator book.
I think you're right. I think driving pressure is going to play a huge role in this. And we require all of our providers to document driving pressure. And what's really cool is the NV ventilator, and I'm pretty sure the Revell, they automatically calculate the driving pressure. I think it says like DPAW or something like that when you do a eye hold on it. And so we take that inspiratory. And if you're listening, you don't know what a driving pressure is, you can calculate it a couple different ways. But the most common is to take your plateau pressure and then minus your PEEP from that.
Right.
And that's telling you what the pressure is going into the lungs between each breath that you're giving. So you're holding the lungs open with that PEEP, and then you have a pressure that has to come over to maintain forward flow. And that's the pressure that the lungs are constantly being exposed to. And I always tell people, if I just come over to you and I push your arm and I'm just holding it, that's not going to annoy you that bad. But if I keep poking it, over time, that's going to become more irritating.
Right.
And so if you can keep the lungs kind of just open instead of that cyclic opening and closing, it's really going to help a lot.
Yeah, and I love that analogy of the keep poking, because that's the whole concept of the new study that was done last year in ARDS and reducing that driving pressure in those subset of patients, right? Driving pressure for you and I is really, it's not a big deal, but you have an ARDS patient that already has inflammatory response, lung injury, then that is a big deal, and we want to keep that less than 15. And so
it's kind of like why you give Esmolol to somebody with like a dissecting aneurysm. You want to reduce the amount of times you're poking it. You want to try to bring that down a little bit. Is that constant pressure? Yeah, that might be why they got there, but that cyclic poking is what really pisses it off.
Awesome. Good stuff. Let's see here.
Hey, what have you guys been talking about?
Mike just came back.
I've been here the whole time.
Let's jump into the next one.
Yeah.
He's been selling stuff.
He has. Mike's been jumping back and forth. So
the water bottle guy.
He's. I think. Yeah, we've given away.
Well, the water bottles are all gone. We're out.
Yeah, we've given a lot of water bottles away. Fallacy or fact? It's all about SpO2, blood pressure, and heart rate.
It's all about blood pressure, SpO2, and heart rate. I guess I would have to follow that as what's all about that.
Yeah.
That's how we gauge our patients as far as are they compensating or are they decompensating? Or what if I said we should use predictive resuscitation and use end tidal, MAP, and shock index instead?
I'm a big fan of MAP, and I think end tidal is really important. So I don't know, I wouldn't just limit myself to 3 parameters to determine if a patient is in shock.
So why are we teaching our new paramedics that? Because that's what we're teaching. Teaching them SpO2, heart rate, and blood pressure.
Well, and if your blood pressure's off, your pulse ox is going to be off. So those two kind of complement each other or argue with each other. And then your heart rate can go up for a number of reasons. That doesn't always mean you're compensating for something. So, like in the podcast I did on ROSC, AHA says if your systolic is below 90, that you need to give 1 to 2 liters of fluid. Systolic at 90, all right, what if it's 90 over 70 something? My MAP's still fine. Why do I need to give fluid? That doesn't make any sense.
Because you got to cover all the H's and T's, man.
Yeah, right.
That's why.
But we look so much at blood pressure
that was a joke,
as systolic, right? And we look at that systolic, and one of the things I do when I'm teaching trauma courses, I give them a patient that was involved in a car accident or something, and I give them a blood pressure that has a perfusing MAP. So MAP's like 70, but it's like a blood pressure of like 86 over 68
I love
or something.
It, dude. I do the same thing. Just suck them right down that rabbit hole.
And I ask them, what would you do? And they're like, I give them 2 liters of fluid right away. They need a bunch of fluid. And then we calculate the MAP, and I don't even know what that blood pressure, if I just gave us it. I think that's a good MAP. I'm not that good at math, but I think that they look at that and like, we give them fluid, and then I take a pressure bag, right? And I pump up the pressure bag, and it's measured in millimeters of mercury. So you can do like a blood pressure of 120 or whatever, and I take the end off of the IV, and I go, this is how fast blood comes out at that pressure. Do you think you want that pressure that high? And they're like, oh God, no. And now when you think about that's the pressure of exsanguination, then you're like, oh crap, no, I don't want that. I want to do permissive normotension. I don't like saying permissive hypotension, because I feel like if you're above 65 or 65, that's where you want to be. So you really got to look at MAP. You look at your cardiac index. You look at all of these things as a whole, and you don't get so tunnel visioned into one parameter. So I would say it's not all about heart rate and blood pressure.
Yeah, and I love a lot of stuff you said there. I think you were spot on everything. I think my problem is that there's a lot of things that are taught at the basic level, and I say basic level of entry-level paramedic. You're coming in, you're teaching a paramedic course. And I'm not saying that we need to teach critical care concepts, but I think it's so easy to see new paramedics or paramedics without critical care experience. And when you're teaching these things, simply looking at tidal CO2 and what does that mean? Looking at SpO2 and understanding what you exactly said. You said SpO2 latency. I mean, that's essentially what you said is if your blood pressure's low, your SpO2
even in a
incorrect.
Normally perfusing patient, you have latency, right?
Sure. You look at the Q-SOFA guidelines, and I was talking about this at dinner the other night with a few physicians. Respiratory rate of 22, greater than 22. Tachycardia. And what's the blood pressure? 100 systolic. Why are we using 100 systolic?
Because
it's
easy.
Know what I was told?
We like it.
By
we
physicians?
like easy stuff.
It's because you're teaching to the least common denominator. And I think that is just, I understand it. I was talking to Sam Ireland yesterday about that I miss being a training officer over 40 people. Because I think you can really have that intimacy.
We were just talking about that this morning.
You can have that intimacy, and you can really make an impact. And it's very humbling. And I was talking to Alan Wolf about this. You take that same kind of mindset, and now you translate that over 1,500 flight crew members, and it is a completely different thing. You can't teach the same way. You can't do it. It's impossible. And that's where I think he really helped me understand that I can't teach at that complex level, that you have to start low and build your team up, because your span of control is just, it's out of control.
I have the same exact experience on 275 people.
That's still,
but it's the same thing. It was so funny because some of the stuff I was trying to teach at my last agency, things I would throw out there, people would sort of spotty attend, right? They'd show up here and there. But when I did something back to basics, I packed the house. And it's just the same thing, right? If you start them down here, that way there's no judgments. Like I care where you are.
Yeah.
But I care more about raising you up. So, man, there was something to be said, like my back to basics 12 lead, right? I mean, literally back to basics was packed. And that gives people more confidence to then come to the axis deviation class, right? Exactly. So to exactly what's your point. I mean,
yeah, and that's not knocking anybody. I'm not knocking anybody.
No, not at all.
I literally understand that when you have a span of control of 300 to 1 or 1,500, not saying that I was directly involved in training that many people, but as part of a team, you're going to have people at different levels, and so some people may need more of your attention, more of your time. They may come in from a different part of the country that didn't utilize those types of protocols, those types of things, and I think that's the tough aspect of training is that understanding that aspect, and so I think end title, map, shock index, I think gives you a much more clear picture of what the patient's doing. It's kind of use the analogy of monitor quality versus diagnostic quality in versus 12 lead versus normal monitoring of a 2 lead monitor.
Oh, absolutely.
Right? It's the same thing.
And is heart rate and blood pressure mean that they're meaningless? No, not at all. And people will say, end title's better than end title's better than pulse ox. They're looking at two different things. What do you you can't look at that. You got to look at what each one says, look at those parameters, and then make your diagnostic decisions based off of that.
Yeah. I love it. Awesome. All right. Fallacy or fact? My patient isn't in pain. No need for pain and sedation while intubated. This was just told to me the other day.
Oh boy, I'm gonna need some more coffee.
Man,
I literally almost passed out.
Did you almost fall out?
So I've heard a doctor say that you should not give pain medication to a patient that is hypotensive and intubated because they need to ride on that adrenaline and that pain that they're feeling.
That's
and that
super
you give
cool.
them fentanyl and it's going to crash that sympathetic drive. Part of that is true.
Absolutely.
Part of that is true. But we don't take care of their pain. We just, like I said before,
use lower doses.
We use lower doses. We understand how much of that is going to be bound to protein in the plasma. We understand that we need to reduce the dose by it. I remember Dr. Ducanto was like, you guys bolus a lot of stuff in emergency medicine. I was like, what do you mean? He's like, you guys just give like 200 ketamine. He's like, I give it in like 25 increments and I try to get the patient to where I want them and then I'll dial off. And I'm like, that's interesting. And I guess, it's not like we're doing a laparoscopic surgery that's elective.
It's sort of apples to oranges.
Right.
I mean, it's
how much is that applicable to EMS?
Right.
We want to get it in. But if the patient is in pain, it's just not even humane. We got to think about it. That's why I love ketamine, because you're really covering both of those fields with it. I do notice that I give ketamine and their heart rate's still a little high, and I'm like, well, are they still feeling pain, or is that the catecholamine release? And there was a really good paper, I can't remember who did it, on maybe we can't completely use heart rate in a patient to determine if they're in pain or not, because other things can aid to that. And I
think
agree.
That's a late sign as well. I think you're a little behind the 8 ball if you're waiting for vital sign parameters.
Well,
to
and I suppose it depends how long you're going to be with your patient, right? I mean, you can trend that over time, but if that's your sole thing, I would agree with you.
I've walked into the ED before and they're like, we got cardizem hanging because the guy's an AFib and his heart rate's been like 120s, 130s. We can't get it to come down. They didn't even consider analgesics. They just considered that he's an AFib, RVR, and that must be something that we need to give cardizem for. We got to control the rate. Did not even phase him that could be due to he's got a big piece of plastic raw dog down his throat, And they didn't even think about that. And so you're like, all right, well, I'm going to give them some fentanyl. The heart rate starts coming down. We don't need the cardizem. If somebody's in AFib and they always have AFib, then AFib RVR is our sinus tachycardia.
Yeah, exactly.
You know what I mean? Like, it's not something that's an emergent situation because they're in AFib RVR. They're usually in AFib. Now it's increased because they're in pain. That doesn't really change the fact that I need to treat their pain, and now I have to all of a sudden treat them with cardizem. So I definitely think that you need to address pain. That definitely needs to be on your, the A1 approach, the analgesics first approach. It needs to be high on your priorities, and it's definitely something that you need to play into their hemodynamics. Yeah, if I give this patient that is running off sympathetic drive 200 mics of fentanyl, I am going to diminish that sympathetic drive somewhat, and I need to either hang a pressor to counteract that, or I just need to reduce my dosing on the fentanyl.
Yeah, so two things that you said, and we'll wrap this podcast up. Two things. One of the things is, and I wish DeCanto was here.
I know, I don't know where he's at. He's running around here somewhere.
Fentanyl guys, and I just had actually another email that just came to mind where, a flight nurse or a flight paramedic wanted advice, said that one of her colleagues just doesn't subscribe to giving pain and sedation, said that there's no need.
No, that's nice.
And I don't remember which one it was. It was one of the two. I still haven't responded. I don't know how to respond to that yet. If
you have an iPhone, I would send them a picture of a clown, and then I would hold down the send arrow to where it populates all over the place and just send that right over.
Yeah.
No, don't do that.
I appreciate her trying to educate her partner, and I understand how frustrating that is, where you maybe you're grasping the concepts, but somebody you're working with is not, and having that battle with patient care. The other thing is guys, fentanyl is extremely hemodynamically stable. I think that's one of my pet peeves. If you look at anesthesia, there's a lot of anesthesia stuff that does translate to emergency medicine or pre-hospital emergency medicine. And I wish, again, Dr. DeCanto was here to kind of, back up my statements. But feel free to do your own research. Is one of the things that they'll do is I've got a lot of friends that are CRNAs. I've got a lot of friends that are anesthesiologists, and I've talked at length about this concept. Is you have a patient that's coming in for open heart surgery, right? Cardiac, going to be put on cardiac bypass. Their heart is just not healthy. Their left ventricle is enlarged. They just have that left ventricular dysfunction. So they're coming in for significant surgery. They've got to crack their chest, and they just can't handle propofol. They can't handle these normal induction agents. Well, how do they do that? They induct them with fentanyl, high dose fentanyl, and they'll give 1,000 mics over 2 or 3 minutes. And what I've been told is you can still actually communicate with the patients, right? It doesn't drop their respiratory drive. It doesn't knock them out. It doesn't drop their blood pressure. They're not slamming 1,000 mics instantaneously. They're giving it like you just said DeCanto does with this ketamine. But they're doing it over 2 or 3 minutes. And some papers that I've got actually stored will show through the entire surgery, they'll give 50 mics per kilo. Now do that math. Right?
That's crazy.
80 kilo patient, that's 4,000 mics.
Oh, yeah. That's good.
Right? And
imagine just calling in your report to the hospital.
Oh, man. So I say that giving 50 to 100 mics to a patient that's mechanically intubated, even if they're hypotensive, if you're giving the lower dose, as Tyler said, ketamine, you have a low perfusion state, resuscitate your patient first. Give them some volume. If you have blood products, start those blood products. Manage the airway BLS-wise. Then give a lower dose. Give, 1 milligram per kilo, or drop it down to even 0.5 milligram per kilo. Give them something that's you need a dose big enough that's going to dissociate them, right? You can't just give them a pain dose or a sedation dose, but it's got to be enough.
And I think it's safe to say that if you have a patient that is running on a sympathetic drive, that is how they are compensating.
Yeah.
They hear that 9 Inch Nail song blasting in their brain, and they're running off sympathetic drive. Ketamine will drop their blood pressure. We know that because it's not that the ketamine is causing a drop in blood pressure, it's just blunting some of that sympathetic drive. But if you have a patient that is maybe just hypotensive, it's not because of one thing or the other. They're dehydrated or what. Fentanyl's not going to actually cause them to become hypotensive, but if they're running on a sympathetic drive, it will have somewhat of an effect. So your patient that is in a car accident that's exsanguinating and their heart rate's jacked up, yeah, you are. I mean, it is going to cut down on that sympathetic response a little bit.
Yeah.
So it's just something you have to keep in mind and then just dose accordingly.
Right. So I think, if we kind of take everything that we've talked about, I think you can kind of wrap all this up and say that, we have to be more definitive in our thought process. We have to be, clinically educated and not rushed. And I think I've heard that multiple times, whether it's our first topic of stay on scene and maybe resuscitate before we rush to the hospital, or, the whole aspect of ketamine versus etomidate. It's not about the medication. Don't blame it on ketamine. Don't blame it on etomidate. We just have gravely ill patients that are hemodynamically unstable that need resuscitation first, and we have to slow down. And I think it's real easy to get tunnel vision, and we can't make the emergency our own emergency, right? Slow yourself down.
Absolutely.
And I've found that one of the things I do, and if you've worked with me, is we'll be in the middle of the worst patient in the world. I mean, vomit's flying, blood's flying, and I'll look over at you and I'll say, hey, you want to have a steak after this? Or I'll make a joke. And a lot of times I do that because I sense that the atmosphere is a little bit tense. And a lot of times, somebody will look at me like, what are you thinking about that right now? But it snaps us back to reality, And it's not that we're not taking the situation serious, but it brings us back to ground level.
I always talk a little bit slower, because if I feel like I'm talking slower when my heart rate's at 120, I'm probably going at just the right pace.
Sure, I think.
But you're going to set the tone for the entire team.
Yeah.
And if you're yelling out, barking out commands, and all right, we got to go, get this up. What are you doing? Then it's going to stress everyone else out. Hey, you better get that IV. If you don't get that IV, we're screwed. You better get that. That doesn't help anybody.
Yeah.
Stop doing that. Relax. All right, if you don't get the IV, we'll put an IO in. Give them a second option. And then everybody kind of relaxes a little bit.
Right. All right. Well, hey, I think this has been a great podcast. A lot of needed stuff, to kind of discuss. Some rumors, some fallacy, some fact. And I think we had a good discussion. I want to thank Mike for jumping in, jumping out.
Yeah.
And,
sorry I wasn't in here more, but you got to take care. You got to take care of the fans that are coming in, wanting to know more about FlightBridgeED. So it's been cool.
Yeah. So. Hey, this will be, a great podcast to share with your colleagues. If you haven't subscribed, please subscribe to the podcast. I want to thank everybody for coming to AMTC. If you came to AMTC and came to my lecture, that was awesome. I appreciate the support. On behalf of Tyler, do you have anything else you want to add?
I want to add that everybody needs to come to Fast 18 and come say hi to me and come hang out, because we're going to have a blast.
It's going to be good.
This is going to be fun.
It seems like there's another EMS conference sort of before that Eric and myself are going to be at. Do you want to talk a little bit about that?
Wisconsin EMS Association. How could I forget?
Yeah.
Yeah, so we are going to have a blast over that. You got Eric, Mike Verkes, Mike Abernathy, Jim DeCanto, Cynthia Griffin. Some really big names are going to be there. It's going to be phenomenal. If you want to check it out, go Google WEMSA. I don't even know the website. It's
WEMSA,
changed.
WEMSA, yep. That's what I did.
Just Google WEMSA. Go ahead and subscribe to it and tell them Tyler sent you.
Yeah, so Fast 18, guys.
It won't get you anything off, though. Your price.
Yeah, right.
Come check it out. March 20th, 21st, 2018. We have a pre-con on the 19th. We're talking, maybe I'm biased, but I'm serious when I say.
I don't think you are.
The lineup of speakers I will put up against many conferences around the world. And, we're talking about Antivi, Dr. Dan Davis, Ritu Sani, Tyler Christofoli is going to be there. Our own Tyler. I'll speak. Ashley Liebig. We have Senior Chief Edward Byers. He's still an active SEAL. And
Medal of
Honor Awards recipient. He's going to lead off the conference keynote. I'm so excited about that.
Plus, it's in Nashville. I can't think of a better area to do it.
Listen to some of these other people. Ginger Locke, Gary Heigl, Brandon Messmer, EMS POCUS guys are going to be there. Dan Rao, of course, Tyler. Michael Frakes, Boston MedFlight, clinical director, is going to be awesome. Dave Olvera, Jeff Beer, Jim DeCannon, Preston Fedor, Peter Antevi, Ritu, Zaf Kasim. It's going to be awesome. I mean, I don't even know what to say. We had a guy yesterday, he said, I'm supposed to be going to South Africa to talk. But he's like, you guys are killing me because I'm like having to decide whether I want to go to South Africa or if I want to go to Nashville.
Yeah,
that says a lot.
Dr. Arshad is going to be there, which is he's phenomenal. You said, Dr. Zafar Kazim, big Raboa guy, phenomenal speaker.
Yep.
So I please, check it out. Come to the website. You won't be sorry.
And if we get a good response from this, I mean, this is going to be the first one of hopefully another one. And we'll do another one. I think that's going to be really cool.
We want to do things different. We don't want status quo. Things are I forgot Howie Mel. Dr.
Howie Mel. He's going to come and kick the cart over.
Oh, yeah. Yeah, he tweeted me last night, and I said, leave nothing unsaid. It's going to be controversial.
Yeah, I told. He says
those are the best talks.
He calls me at 11 o'clock at night, just the other day. He says, hey, dude, I'm right between patients. What do you want me to talk about? I said, well, what do you want to talk about? He said, let's talk about anything. I said, what are you passionate about? He goes, and so he gives me the topic. He goes, is that too hard? I said, no, dude. Is he going to piss people off? Yeah. I said, good.
It could. Yeah.
Good. So there'll be 2 camps on his topic. It's
awesome.
good. It's going to be good. So
yeah. So we're not doing hour talks. We're doing 25 minutes.
Yep.
We're going to do a debate. Tyler and I are going to do a debate.
A ventilator, a vent off.
The vent off.
We're going to have a critical care panel.
Ventilator showdown, which will be hosted by myself, Mike Verkest. We'll be taking questions via social media.
We're going to dress up like Rocky and the Russian.
Yeah, that's right. You will lose.
Yeah, it'll be fun. A lot of fun. So, hey, check that out. Go to the FlightBridgeED website. Top of the banner, far left, Fast 18. Again, pre-con, you got the hand-heavy pediatric course.
Yep.
You have EMS Focus, and then you have Dr. Dan Davis's ART training, which is truly a revolutionary way of managing cardiac arrest patients. I can tell you that AHA has taken notice.
Yep.
That's all I'm going to say. And so he's teaching that all around the world.
And so are the people that used to go to ACLS class. They've taken notice as well.
Yes. So phenomenal stuff. So thank you again for all the support, and we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.